Okay, well, thank you for having me. I'm Chris Rausch. I'm one of the pediatric cardiologists here at Children's Hospital and University of Colorado Hospital. And we're going to go through critical congenital heart disease and newborn pulse oximetry screening for that. I've got a lot of slides, so I'm going to go through some of them very quickly. Certainly don't hesitate to send your questions in, interrupt me along the way, and if you have any questions. Otherwise, we'll answer those at the end. So just briefly, we're going to go through a patient case. So this was a 8-day-old term baby who presented to the pediatrician's office for poor feeding, sleeping more, didn't have very much energy, wouldn't take a bottle, and the parents thought the baby looked kind of pale, hadn't been making as many wet diapers the past half a day or so. In the office, the pediatrician noticed that the heart rate was fairly high, that the blood pressure was a little bit higher in the right arm as compared to the right leg, and that they had a hard time getting any oxygen saturations anywhere because the skin was sort of mottled and cool, and the capillary refill was prolonged at around 5 seconds. A few laboratory tests were performed, and so we sort of have a few options for what this likely is. In this case, it turns out to be B, coarctation of the aorta, which we can see here. My echo images won't play, but that would show sort of a classic picture for a narrowing of the aorta on its way down to the lower half of the body. So by way of background, congenital heart disease is one of the most common birth defects worldwide. About 1% of births have congenital heart disease, and it's the leading cause of birth defect-related deaths. There's a subset of congenital heart disease known as critical congenital heart disease, which are those babies who need to have something performed, some sort of treatment in the first days and weeks of life. And that makes up about a little less than half of all of those congenital heart disease defects, so about 0.5% of all births. Every day in the U.S., babies are born with a wide variety of disorders, and congenital heart disease makes up a large chunk of that. You can see there in the blue pie up on the right-hand side. And for those things that we screen for, some of the other underlined items along the list there, congenital heart disease actually makes up a larger percentage of birth defects than a lot of things that we were screening for many, many years now. So in the early 2010s, several papers came out recommending that perhaps we should be screening babies for congenital heart disease and trying to identify some ways that we could do that safely and effectively and cost effectively. Based on those early studies, it was recommended that we start screening babies for critical congenital heart disease. And so several different disease types were identified as being primary targets for this screening. And we'll just touch on each of those very briefly. So hypoplastic left heart syndrome is present in about 1 to 3% of all congenital heart disease, but is really one of the most important causes of early death for infants. Up to 25% of deaths in the first week of life are related to hypoplastic left heart syndrome. So very important cause of morbidity in our infants. These babies oftentimes will not have any symptoms. So less than a quarter of babies will present with symptoms in the first 24 hours of life, and many of them will have a nice normal heart exam at the time of discharge at 2 days of life. And that's why it's so important that we identify these kids before we send them home, because they're going to look very normal when it's time to send them home from the hospital. But as we just discussed, many of them will go home and have a very bad outcome if we don't identify this disease. Pulmonary atresia is another common cause of critical congenital heart disease, around 1 to 3% of all congenital heart disease. And these babies similarly will have a pretty variable presentation depending on their anatomy and the size of the ductus arteriosus, the connection between the aorta and pulmonary artery that supplies blood flow to the lungs in this case. And if they have a large PDA, they might have a fairly normal exam and be sent home without any suspicion of congenital heart disease. Tetralogy of Fallot, this is the most common form of our cyanotic or blue heart disease, and this is about 5 to 10% of all congenital heart disease. Similarly, these babies could have a very mild presentation with almost no heart murmur, or they might have a very loud heart murmur that's easy to pick up in the newborn nursery. So it depends a little bit on the anatomy for this population, but again, a high risk of sending these kids home without having any idea that there's something wrong. And then total anomalous pulmonary venous return. My picture's sort of shuffled around there and covered part of the words, but TAPVR. This is a much less common congenital heart disease, less than 0.5% of all congenital heart disease. But importantly, 75% of these babies, if not recognized, will die within the first 3 months of life. And this one can be very difficult to pick up. It often doesn't show up at all on the physical exam. Transposition of the great arteries. This is one of the more common ones where the great blood vessels going to the body and to the lungs are switched in their location. These babies will become very blue and very sick quickly, and without treatment, up to 50% of them will die within the first month of life. So again, very important that we identify these kids before they get sent home. Tricuspid atresia, 3% of all congenital heart disease, and these babies also may not have any heart murmur and may not look that blue in the hospital and could very easily be sent home and not identified until much later, which might be too late. And then lastly, Truncus arteriosus. So this is when you don't get division of those big blood vessels going out to the lungs and to the body, and everything comes out in one place. That's about 1 to 2% of all congenital heart disease, and these babies often will not survive beyond a month, again, if not identified early. So how do we identify these target lesions? We'd love it if we could pick all of them up prenatally and identify it so that we can counsel families and have babies born in a hospital where they have the appropriate care. But unfortunately, that doesn't work as often as we'd like. Only about 50% of these critical congenital heart defects are picked up prior to delivery or identified before delivery. And that's even when you have very good prenatal care. And we're getting better and better at this, and some of the newer studies are showing that we can be more successful at this if we have good prenatal care with good identification of the heart structures during prenatal ultrasound, but it's still far from perfect. So that leaves postnatal. How do we find these babies before we send them home? Some of the time, many of the times, the oxygen levels will only be slightly low and not low enough to cause any bluish coloration to the skin for babies, which has to be around 80% or below. So the babies have to be pretty desaturated to have that bluish coloration. And as we discussed going through the individual heart defects, many of the defects won't have a significant finding in those first few days of life. So you can very easily miss these babies and send them home thinking that they're a nice, normal, healthy baby. The problem if we miss the diagnosis is that many of these babies either will not survive or will have significant injury to other organs as a result of this poor blood flow. And that results in long-term morbidity for these patients and for their families. So specifically for Colorado, we would estimate about 700 births per year with congenital heart disease. And of those, about 280 or 300 will have critical congenital heart disease, which means that based on the numbers for prenatal screening and for just using physical exam skills alone, about 90 to 100 babies each year would be missed who would have and would be sent home with critical congenital heart disease. So several states before Colorado were experimenting with the idea of using pulse oximetry to help identify these babies while they were still in the hospital. The advantages are that pulse oximetry doesn't cost that much, it's painless, it's non-invasive. Most families have seen a pulse oximeter before, so it's not that scary, and it's available in every hospital. And using a cutoff of 95% for a lower extremity, one study suggested that up to 81% of critical congenital heart disease could be identified, and several studies followed shortly after there, which demonstrated that if you looked at babies greater than 24 hours of age, with a very low false positive rate and a good sensitivity and specificity, you could identify critical congenital heart disease. And then another study, again, shortly after that one, showed that a very low false positive rate, 0.2%. So based on that, nationally, a algorithm was established that looked at pulse oximetry in babies in an iterative way, where they're checked at around 24 hours of age, and then they have to meet a set of criteria to either pass, be rescreened, or fail the screening test. And then if they come into the category of being rescreened, that's checked again about an hour later, and one more time an hour after that, if they don't either pass or fail at each time point. And those babies who have a positive screen, then the recommendation is to go on for further evaluation and consideration for a cardiology visit and an echocardiogram. And those babies who pass the screen are considered to be normal. Several studies looked at how cost-effective this was and found that really, once you got used to the process, it was fairly inexpensive, didn't take that much time. And again, because all hospitals have pulse oximeters, there wasn't a lot of upfront cost to buying new equipment and things like that. The only limiting factor is that for some smaller hospitals, they don't have immediate accessibility to pediatric cardiology, and so that could certainly add expense if babies needed to be transferred to other centers for that. One of the challenges that we face here in Colorado, as well as some of the other mountain states, is that there wasn't a lot of information about pulse oximetry at higher elevations. And some of the studies that had been performed historically showed much lower oxygen levels for babies at our altitude, and a much wider range of babies even who were otherwise normal and healthy. So several studies are shown here that show starting at sea level and then sort of moving your way up to higher and higher elevation. You can see how the oxygen saturation averages get lower and lower, and how the range of those saturations gets bigger and bigger. So based on that, in the early 2000 teens, we did a study here at University Hospital looking at about 1,000 babies who were otherwise normal, healthy babies, and performed pulse oximetry. And what we found is that these primarily term babies and some early or near-term babies had very good oxygen saturations of around 97% on average, both upper and lower extremities, but that there was a somewhat larger tail where the babies had lower than 95%, or lower than that cutoff that we use for the screening protocol, and that those babies then would be at risk of being identified as a false positive in the screening. We found overall from those 1,000 babies that about 11 babies failed, so just over 1% of failures, which was slightly higher than what we see nationally, but we still felt that was within a reasonable level to go ahead and recommend that pulse oximetry screening be implemented in Colorado for all babies who are born at lower than 7,000 feet elevation. We did several smaller follow-up studies at other centers at higher elevation and found that 7,000 feet seemed to be the cutoff to make it feasible to do this test. Some babies born at our really high elevation centers we were seeing failure rates of close to 50%, and so it just wasn't feasible to implement this strategy at those centers. Fortunately, most of the babies born in Colorado are born below 7,000 feet, so last time I checked our Colorado Department of Public Health registry, we were capturing well over 90% of babies born in the state. And with some help from Children's National, we developed a critical congenital heart disease toolkit to help hospitals implement this program. And since then, nearly all hospitals in the state below 7,000 feet are doing this routinely. So we'll skip case number 2. I just want to say thank you to several people who helped out with this study. Really a great group of folks who spent a lot of time thinking about this and getting critical congenital heart disease screening implemented both in Colorado and helped as well with some of our neighboring states. Okay, any questions about anything I covered there?
Not have any questions via group chat. However, looks like we do have one that just came in. So sorry. Does the screen include an upper and lower extremity simultaneously? And what is the false positive rate from universal screening?
So the screen in Colorado, the recommended screening involves a right arm and then either leg. And that's performed either at the same time or in immediately following. So right arm and then immediately one of the legs. We do not have false positive rates for Colorado because we aren't able to do echocardiograms on all those babies and prove that they don't have congenital heart disease. We did some smaller studies at higher elevations where we actually tried to do echoes on every baby, and that proved to be extremely expensive, and we just didn't have the money to continue that sort of a study in large numbers. So we don't have false positive rates at this elevation.
Any other questions for us, Stefan? Our office is doing screening at the 2-week office visit.
So the national recommendation is to do it in the first 24 to 48 hours of life. And the real reason for that is that if you send a baby home who looks normal at 48 hours of life, they could go home and have closure of their ductus arteriosus and have a sudden death event or severe brain injury as a result of not enough forward blood flow, and that could happen at any time in those first few weeks. So to get the most utility out of this test, it should really be performed in the first 24 to 48 hours of life before the baby goes home from the hospital.
Any other questions for us, Stefan?
Not right now.
Thank you. Well, for our audience, I have unmuted the majority of microphones, so you are definitely welcome to chime in and submit a question for us if you'd like. Otherwise, I will definitely continue to take questions from you via group chat. All microphones are open. Anyone has a question, please feel free to address it now.
Karina, while we're waiting for questions, I think we have plenty of time if Dr. Roche wants to go back and do that case.
Second case?
Sure.
Maybe
Sure.
that'll spur some conversation.
Yeah, we can go back and look at that.
Thank you.
So the case 2, this is another term baby born about 6 hours ago. Mom is healthy. Pregnancy was uncomplicated. The delivery was uncomplicated, and the baby looked great. The vital signs show a heart rate of 160, respiratory rate is 82, and the oxygen saturations are low at 80%. So the baby looks to be working a bit hard to breathe, as you saw with the respiratory rate of 82, and looks sort of bluish around the mouth and chest. Otherwise, a fairly normal looking exam, but the baby's just working hard to breathe and is a little bit irritable. You obtain a blood gas that shows some metabolic acidosis. And then a chest x-ray demonstrating this view here. So what do we think this baby has? Oh, we don't have an answer. So this is a transposition of the great arteries. This is those babies typically get very blue very early on, and so to have these low oxygen saturations, the great arteries are reversed, and if you don't have a good opening in the atrial septum, then they don't have very much mixing of the blood, so you're just sending blue blood back to the body and red blood back to the lungs, and you're not getting oxygen to where it needs to go. So these babies will often get sick fairly early. If they have a large atrial septal defect, then you might get more mixing and they might not get as sick as quickly. And again, if the oxygen saturations are in the mid-80s, they might not look that blue. And so you could easily send a baby home with this if they didn't have a loud murmur, which many times they won't. And they could then get very sick at home with these oxygen levels in the 80s.
One question. Are infants and families with a history of congenital heart disease given special screening in utero to look for heart problems?
Often, but not always. So many types of congenital heart disease are not related to a genetic syndrome, though the more we learn, the more we find out that genetics are involved in many things. So we know that if a parent had a prior child with congenital heart disease, their risk of having another child with congenital heart disease goes up slightly. So normal is around 1% in the general population. Many times we see an increase up to around 3% for a prior birth with congenital heart disease. For that family, the risk goes up to 3%. So oftentimes they will get more advanced or higher level prenatal ultrasounds if that's available in their community. If there's any concerns on that, then they'll get sent for prenatal echocardiogram if that's available in their community.
Thank you for your question.
I have a question. This is Vicki. Is there surgery to help a baby that has that second case?
There is surgery for all of these. So all of these critical congenital heart disease defects, if identified, we can do surgery that will help the baby. And many of them will go on and have very normal lives. And so a big difference from sending them home and possibly not surviving, being sent home, to having a nice normal life if we identify them early and get them the surgery and the care that they need.